in a minute, as well as the guest speakers for this parallel session. I just would like to make sure that we have our online speaker on Zoom. If you can be so kind to open the camera, please.
Get ready to.
Hey, Seval, good to see you from Turkey. Dr. SevalAkgün from Turkey, unfortunately could not be here with us in presence. We are not listening to you. Can we test sound, please?
Unfortunately, actually, I would like to join you in person, but unfortunately, we couldn't make it this time. Hopefully next time.
Hopefully next time, but at least we'll have the contributions from your perspective as an international manager and also expert in the field. We are talking here in a session about hospitals, so it's going to be.
Thank you.
Any others, guest speakers, please, remote speakers? I think we have someone else from Belgium to join us over Zoom. If not, I think we can start and proceed, not to delay more this session. And again, welcome all, and welcome for all the almost 40 participants we have on Zoom. We are now live also on social media in multiple channels. It's great to have your participation in the Health Data Forum Global Hybrid Summit 2022 edition. It's an honor and a privilege to have here as a chair of this parallel session, Professor Fernando Araújo, formerly the CEO of this large hospital that the participants here on site are witnessing, the Hospital São João, which is a reference hospital in Portugal. And now is the Chief Executive Officer of the National Health Service in Portugal. So it's an honor to have his time here with us and to moderating this session. And the floor is all yours, Professor Fernando Araújo.
Thank you. Good morning. First of all, I would like to thank Faculdade Universidade de Porto, MEDSIS, for this kind invitation and congratulate Professor João Fonseca for this excellent forum. This session will be dedicated to hospitals and how these serve as data providers in the healthcare ecosystem. The goal of the discussion is to develop calls to action, which will be presented during the keynote of the PAC. Session will take something like 60 minutes. Every speaker has 10 minutes to present. That leaves us some time for discussion at the end. So I will ask the first speaker, SevalAkgün, Chief Quality Officer of Baskent University Hospitals Network, in order to begin with her presentation. Thank you.
Thank you very much, Professor Fernando. First of all, I would like to thank Mr. Paul and also Congress organizer inviting me to here, giving me opportunity to share our experiences. Let me share slides with you. Is it okay?
Not yet.
Okay.
Okay.
Okay, yes. Mr. Paul requested from me to talk about the electronic health record incentive programs for hospitals, especially for junior staff. Actually, my problem is not with junior hospital staff, with senior hospital staff. But I would like to share with you very briefly how all these electronic medical records, indeed, at the hospital, we mainly using electronic medical records, how this electronic medical records change our life in the hospital, as well as at the country level, giving some examples from 2 different countries, including one is mine and one is the developed country. And actually, I think we are also doing very well in this electronic health records as a country level. I think we have 1,500 hospitals in the country, and all have the similar system. Of course, I'm working as a big network, chief quality officer, almost more than 25 years. So I can make these differences before and after very well. And we are foundation hospital hospital, so a little different than state hospital, but state hospital also doing very well and having the similar system, because at the country level, it's almost mandatory now. So I want to very briefly summarize. I know that you are discussing all these issues since last 2 days, but when we say electronic systems, we say point of care system, that is electronic medical record. So it allows us entry and viewing of data within our organization. We have electronic health records, almost all countries now, especially during COVID-19 period. I think we strengthen this area very much. So this is viewing across multiple services and across a lifetime. And we have patient health solutions. This is very, very important, actually, as a quality person. Patient engagement, patient-centered care, patient-focused care is very important. So this system also gives opportunity to our patients, enables our patients to review, especially review and share their personal health information. How this change our lives? Of course, change a lot. Legibility, I mean, as a physician also, we all know that our handwriting since a huge problem since the beginning. With this system, this legibility, availability, ease of updating, storage, and most importantly, improve our patient safety a lot. And also, you know, when compared with our old times and this time, we are now much more working as a team and collaborative approach. Of course, result our outcomes, improve our communication, increase quality, accreditation system, and accuracy of information. Still, we have problems, of course, so data quality because of entering sometimes not accurate or reliable data. But if you have a good system, if you have a good quality and accreditation system, you can solve also this problem. So for our patients also give opportunity for them to monitor and manage their diseases. It reduced waiting time, use diagnostic screening results, it reduced unnecessary repetition, and information sharing is possible. But of course, to my career in this hospital network since 30 years ago, we had very good health information system. I don't know the upfront cost so much, but at the country level, I know that at the beginning, it's always to set up a good system costs us some money. So nowadays, the main problem is protecting privacy. So we are so much keen on this issue. GDPR is really helping us a lot. We have also a similar system, as you know well, that we are not EU country, associated EU countries. So we have also a similar data security system like GDPR, and almost all hospitals strictly following, because we have also many audits and many surveys on this, strictly following. Strictly following. So then we look at the electronic health system at the hospital level. What are the main tools we are using? We are, of course, all digitalized. Most of the system now, already HIM6 or HIM7, so almost all area digitalized. But we mainly very much benefiting on computerized physician order entry system and clinical decision support system, as well as for electronic health records, health information exchange. So we all know that clinical decision system, I'm not going to the details, also the computerized physician order system. If you look at the incentive program that actually you requested for me to talk on, this incentive program in United States also is meaningful use or PI, initially provided incentives to accelerate the adoption of electronic health records to meet program requirements. All the physicians must use certified electronic health records technology and demonstrate meaningful use through an intensive process at the end of each meaningful use reporting period. In United States, they have an annual, for Medicare and Medicaid, as you know very well, this program provides an annual payout to healthcare professionals who adopt electronic health record software into their practices. In our system, maybe we are not providing directly some incentives, but indirectly, the Social Security Institute provides this payout through reimbursement scheme. We have the EHRG system, and for each procedure, there is a certain amount of that the government, because we have a universal health insurance system at the country level, and most of, for instance, in my network, 95% of my patients have that universal health coverage, so reimbursing the government all the costs to the hospital. So if the system is good, and they have, of course, teams in Social Security Institute, as well as at the organizational level, there are teams who are checking all the quality of data, sending to, or they are actually extracting data from our system, because all the systems link to Social Security Institute system. So they are monitoring all the data is there, and the teams, clinicians also included in the teams, reviewing the data quality and accordingly edit to that scheme. So if it is good, if there are some problems, they are not reimbursing. So it is a kind of also incentive for the hospital as well as to the physician, because we have a fee for performance system. So these financial incentives help providers meet the cost of upgrading their technology and give them an opportunity to stay ahead of the curve. And the amount of their payout depends on the type of the facility, and as already mentioned, the type of the incentives. So this interoperability involves exchange of information between multiple healthcare providers. This is electronic health records. Indeed, for instance, let's a patient change providers or sees a new specialist in a different hospital rather than, for instance, my network. So rather than starting over from scratch and providing their personal information over and over, electronic file also can follow them. So my physicians easily enter to their electronic health records and check everything. For instance, we are not allowed to request MRI or tomography again within the 1 month. There are some certain amounts for each procedure also. So this helps to provide a new physician with all the necessary patient information to get started right away, leading to more accurate treatment or diagnosis the first time around. There are some criteria, of course, all the computerized CPOE, all the computerized provider order entry there. Not all the hospitals, I must tell you, I must admit that this drug-drug interaction, there are this software not so a little costly, not so cheap. So some hospitals actually at the country level not using. We are using. We have 10 hospitals in the network, so we have good softwares, very comprehensive softwares for drug-drug interaction, drug-food interaction, drug-allergy interaction checks. Also medication allergy checks. Of course, all the demographics, all the vital signs there, because all digitalized system. Actually, smoking status, we are not so, the data entry for this kind of information, not excellent, but smoking status, because not related with the reimbursement scheme. So maybe that is the reason. We have very comprehensive clinical quality measures. I will touch that area more. Around 250 clinical quality measures for those selected clinical procedures. So outcomes, and some of them also process measures. We are entering the data Actually, we are calculating and entering the data, but Social Security Institute, they are pull out all data from the systems, and they are calculating, they are benchmarking at the regional level and, you know, at the country level, and sending to the hospitals or sending to the providers that this is your situation, you are above this level, you are below this level, and if you are below this level, so please send us the reason why your measures not fitting the national or regional average. Critical decision support system, not all the hospitals again using, we are using, but not all in all hospitals. I mean, 10 hospitals, some hospitals have very comprehensive critical decision support system, do not have. Actually, it's really improve the quality of data. I already mentioned about the lab results or the radiology image and so on. So in the meaningful use, in each stage, there are specific objectives, and according to objectives at the beginning of the program, the incentives program also change. And there are also some...
sorry, we are out of time, so can you finish your presentation?
So, yes, let me finalize with the clinical quality measures. Clinical quality measures use data from electronic health records and electronic medical records sometimes, and we have many quality measures, and this is a kind of value-based system. So not only, you know, the reimbursement scheme, not only calculating the volume, patient volume, but also checking the quality based on all those indicators and accordingly reimbursing. So as a conclusion, these intensives are a way for healthcare providers to provide a better service to their patients at a reduced cost. The physician offices also using this system, not maybe very comprehensively like us, like a large-scale hospital. So as a whole, these programs are a step toward a more accurate and well-designed healthcare system for everyone. And as I already mentioned, that if I compare our old time and today, the patient safety and our accreditation programs also working well, and patient safety increase a lot. Thank you very much.
Thank you, SevalAkgün, for your presentation. At the end, we could make discussion at the end of the session, and so I will ask next. Dr. Rhidian Hurle, Executive Medical Officer of the Digital Health and Care Wales, that is present here with us to make this presentation. Thank you.
Thank you very much, Chair. We've only got an hour, and my colleague has consumed a vast amount of time there giving you slides about things you probably know. I'm going to talk about leadership in data collection, because leadership, an example, is what we need to focus on at a local level to aggregate local data into regional data, international data. So I'm going to start with the foundation, which is it's a collective responsibility for everyone to collect data. Recognition is the first thing that I would say. It's a professional duty. Doesn't matter what level of seniority you are as health staff, it's a professional duty to record in the record as accurately as possible the care that you're providing to an individual. For safe transfer of care, you should do that in a way that is understandable by the people who then receive that patient for further care. So we must focus on the patient journey, and I go back to a comment I made yesterday about patient-centric care. One of the advantages of doing this is that you can align to best practice, and you can prove that you are delivering best practice because you have the data to demonstrate it. And you can use that as recognition to your physicians within a hospital environment as best practice. There are some interesting cases across the UK. Queen Elizabeth in Birmingham is an excellent example where the chief executive, who's an anaesthetist, identifies individuals who are very good across the consultant workforce and individuals who are performing suboptimally. And he invites them to meet the board. And if you get the letter that says you are suboptimal, you can understand what's going to happen. You are going to be buddied up with someone who is excellent so that you can learn that practice. That creates an environment of, A, not wanting to be the person who gets the letter to improve, but also to learn from each other. So there's a collaboration there, recognition. Another element of it for me is reward. It's about making your teams feel valued. How do you do that? You value them as a team. Maybe it's you take them for a coffee after the ward round. Maybe you have individual chats, understand what's going on in their lives so that when they're in work, they are performing to the best that they can perform. You need to invest in their professional development. There's a bit of give and take here. Data that they collect in the delivery of the service can be used for logbooks. It can be used for audit. And if they structure their data and help you in the process of delivering care, there's a good chance they might get publications. They might get posters at presentations such as this. They feel valued. It enhances their CV. It improves their career prospects. So if you show and demonstrate that data gives them some benefit as to them as an individual, then you might get some return on that time. One of those elements that you can't do, or we can't do, is we can't incentivize people through money. We don't do that within the NHS. Other health services might. If you look at Kaiser Permanente as an example, the better you perform, potentially the more you earn. So you have to be cognizant that you have to develop value in other ways. And I suggest that we invest in understanding our staff and making them feel valued, particularly perhaps the newer generation, the millennials, and perhaps the snowflakes who need more help than those who were born in the last century. Workflow is a very important part, okay? So get people to add things that only they can add that adds value. Please don't ask a surgeon to record the time of an operation starting, or indeed the time that it finishes. Get them to record the thing that only they can record in a structured way. Keep the main thing for each element of your workforce. It's important that you don't overburden individuals recording things that can be recorded in other ways. You can also adopt the approach where you must do this first to do that later. And a very good example, again, from Queen Elizabeth Hospital was their ability to reduce the incidence of deep vein thrombosis, so clots in the legs, and also the infection rates relating to MRSA. And what they did is everyone has to prescribe the stockings, the Clexane. Everyone has to prescribe the treatment, be it nasal treatment or groin treatment, whatever, for the MRSA. And then when the swabs go to the lab and the labs show it's got infection, guess what happens? It comes through automated from the LIMS system and it appears on their electronic chart. There is no chasing of the nurse having to chase the doctor to prescribe it, or indeed the pharmacist to dispense it, because it's there. It makes a real impact on patients. So be smart. And we know about the specific and the measurable and assignable and realistic and time-sensitive things. And again, consider the time balance. What are you asking your staff to do in the collecting of data? Is it seamless in the delivery of the care? Do they actually notice they're doing it? And good UI systems, good user experiences, you're delivering the care, you just happen to be collecting data on the way. And to facilitate that at a local level, you must invest in hardware. You must invest in connectivity. You must make the harder things easier. And that requires a sustainable investment program. And it's quite hard at a board level to get your directors of finance to understand how key that is to collecting data. So you must also give your colleagues the opportunity to validate the data that they are collecting. Be that audit, etc. And therefore, you need to provide them user interfaces that are intuitive, provide training for them, provide support. So an example that I'd like to give you from Wales is we put the Welsh Clinical Portal, which is accessible to 35,000 users across Wales, providing data that it's on my mobile phone here. So if I get an email with an NHS number, I can look up that data, I can see those results, I can directly enter into the record, and I can do that anywhere in the world. It is making it easier for me to do the right thing in a structured way. So, Chair, let's show leadership. And people often say, we should do that. When they say we, do you know what they mean? They mean you, okay? What we need to do is be us. So I want us as the community of leadership to show how it can be done, lead by example, invest in our staff, and we should all receive the collective benefit of doing it. Thank you.
Thank you very much, Rhidian. I have some questions to you, but at the end I'll put. So next we have, I don't know, we have PeterDe. I think it will not be with us, Paulo. Okay. So we pass to Dr. Carlos Santos and Dr. TiagoAlfaro from the University of Coimbra Hospital that will present us a team that is very interesting, I think, about biobanks. Yes. Thank you very much, Dr. Carlos Santos and Dr. TiagoAlfaro.
I would like to salute the chair of this session, Professor Fernando Araújo, all the speakers of this session, and of course all the audience. And I would like to thank the opportunity and the invitation to be here and to present you the brand new biobank of the Clinical Academic Center of Coimbra. We have a presentation, but I think I will skip it for the sake of the schedule. Anyway, the biobank of the Clinical Academic Center. The Clinical Academic Center of Coimbra is a consortium of the Centro Hospitalar Universitario de Coimbra, the teaching hospital center in Coimbra, and the University of Coimbra. And it started in last September 19th, and on the very next day, we received the first collection of samples from a protocol with the Portuguese Society of Cardiology within the Porto study. Porto stands for Portuguese Heart Failure Observational Study. So we have 2 months of activity, and I would like to give you some context information about the hospital. This hospital center has 2 general hospitals, 2 maternities, 1 pediatric hospital, and 1 psychiatric hospital. Broadly, we provide every range of services. I will skip the facts and figures, but it's important to say that we have around 8.5 thousand member staff, more than 6,000 million euros of budget, and we are the only hospital in Portugal that is part of the M8 Alliance, which is probably the most important organization of clinical academic centers and teaching hospitals in the world. We are member of that of the M8 Alliance along with the University of Coimbra. The biobank of the Clinical Academic Center was financed in equal parts by the hospital center and university, and the main purpose is to collect samples with the high quality standards, of course, anonymized, to be able to be used by the community, the national scientific community and international scientific community as well. The main goals are taking advantages of the synergies. Of course, innovation is one of our main goals. We in the near future, we will be able to carry out the molecular and cellular characterization of the samples, so they will be much more attractive for research purposes, and of course for teaching purposes, as well as to improve the quality of healthcare that we provide. I will skip some of the slides only to go to the final of my intervention, to the end of my intervention, just to tell you two or three things. First of all, the biobank will be self-sustained. That's one of the main purpose is to provide services and be paid for those services in order to be self-sustained. And the second thing I would like to tell you about is about the governance model. The biobank as a technical coordinator, as also a scientific commission, external scientific commission, and within the hospital, the biobank is part of the develop and innovation and develop units. I have with me the TiagoAlfaro. Professor TiagoAlfaro is the director of the development and innovation unit. Biobank is part of this unit, and will tell you about the main purpose of the biobank. Thank you very much.
So hello to everybody. First of all, I would like to show my gratefulness to Dr. Carlos Santos for bringing me over here as well. And I'd like to say hello to all the table, of course, Professor Araújo. Continuing on Dr. Carlos Santos, the biobank is new. We are very proud of it, and we think it will have quite an important impact on research on the hospital. The biobank is included in a mostly research dedicated building that was renewed for this, and also includes the clinical trial center. So with ample space, and you can see inside it's quite nice. It's quite well built, and we have quite the space for many samples. We also have the capacity to make automatic analysis and DNA extraction from the samples, and they can also be stored in an automatic way so that samples are anonymized, immediately taken to the fridge, and they will be always identified to a code that is automatically built. Of course, all of these, the space, the people, the machines, they could be achieved through a very nice collaboration and a very clear support that we have from hospital leadership, Dr. Carlos Santos, from the university. Here we have the rector, also the director of the medical faculty, all in the biobanks signing the internal regulation and the agreements for this and for this continuing. As is something new, we also, of course, had to have some help in building this, and we are very happy that we had the help from Dr. or Professor Alberto Warfo, which is original Portuguese, as we know, and he built a very, very successful DNA bank in Spain. So he was helping us from the beginning, and he will be continuing helping us. Of course, you get genetic data, that's what you have in a biobank, but it's also very important to have health data. We've been discussing this all day, and this data has to be adequate and has to be well stored in an anonymous and in a way that it can be also reached. And we have a portal, we have a specific software that can be where the clinician that is taking the samples can already put there some information. This is anonymized, and it will be also used to get the data, to give the data to further researchers in the future. An important part is that our informed consent for the biobank allows for the inclusion of samples and projects that are already ongoing on the hospital and the university. As you can imagine, a very large academic hospital already has a lot of projects that are ongoing and have samples. And we can include these samples in the biobank as long as they pass the quality tests and, of course, have the adequate consent. But this is very nice for supporting ongoing, not only future projects. Also, it's very important that we are from the beginning on the Portuguese biobank network, biobank.pt, and the hospital CHUSJ is also included in European infrastructure, such as the one for the clinical research, the one for translational research, and we hope and we desire that Portugal in the future would also be included in infrastructures for biobanks. For example, the BBMRI. We are not a member at the moment as a country, but we hope Portugal will be. As Dr. Carlos Santos said, the biobank belongs to the Clinical Academic Center of Coimbra, Centro Académico Clínico Coimbra. And this means that we have partners, very close partners with the university, is also part of the university. And of course, in the university, there's a lot of capacity and possibility to collaborate, for example, in data analysis. And we are, of course, working on that. Dr. Carlos already said important is that you start to work, that you have samples, and we already are receiving a few dozen samples a day from this national cardiology study that is representative of the Portuguese population. So starting things as we started now, things will be certainly more effective in the future. So continuing on what was said, we see biobank as a very important support for researchers in Coimbra, that they feel supported, that they will generate more data because they feel we are there doing quality work with them. And this will advance local research, but of course, national and regional as well, and international. And good research leads to good clinical care. And this is, of course, the most important. That's all.
Thank you very much, Dr. TiagoAlfaro. And now we have something like 20 minutes for this discussion. And first I will open to any question that could be put here or outside. I'll do note questions that came from abroad, Paul.
Not yet questions, but we have good comments.
Okay,
Like
okay.
The presentation of
Okay.
Rhidian. Anyone for questions?
Thank you. I was very happy to see the talk about how Wales is doing. Actually, I was lucky to be in Wales just a couple of months ago in the conference on health informatics. And so it was obvious the dynamic that you are actually managing to put into place there. And so, first of all, congratulations on that.
Thank you.
And my question to you is on how do you think we can increase the leadership that we need, because I imagine that we need it on many different levels. And so how can we make new leaders in this digital health area? That is something that for sure we need.
Yeah, that's a very interesting thing. So it's a journey. The WACTA review that was published, the NP failure in NHS England, after a vast investment, had 10 recommendations. 3 of them were on clinical leadership. You cannot deliver digital change in healthcare systems without clinical leadership. Now, in many organizations, you have a board and you'll have your director of finance, who's an expert in finance, and you'll have operational delivery or chief operating officer, etc. But where is the informatics on the leadership board? So there are 2 approaches. You can either say it's everyone's responsibility to do informatics, and that would be my approach. And the reason I would say that is if you give each one of your board members a digital program to deliver, they suddenly realize how difficult it is. If you give it to one person, it's just one voice across the table. So that's the first thing at a local level. The second thing I would do, and this is a passion of mine, is I get people to walk in the shoes of the people in the front line, and I get policy leads to do that. So I actively go to government And the digital team, the civil servants, they come and spend a day with me. They see the environment in which we're trying to deliver care. They see the dependencies on digital systems. And they go away with a very different view, a very, very different view, because it was John Le Carre who said, viewing the world behind a desk is a very dangerous place to view the world. You've got to be in and amongst it to understand it. And that will promote collaboration. So my final point would be about clinical leadership. What tends to happen is we ask for volunteers and they give up their time, but the work that they were supposed to be doing remains. And what happens is you get tired of volunteering and you should be given some accountability, some responsibility and time to lead. And you will have people who are in charge of audit. You will have people who are in charge of morbidity and mortality and harm reviews. You must give people within your environment an opportunity to lead and build teams of interested clinicians who can then engage in that digital transformation. I go back to that thing about it's us and it's a collective responsibility for us all to do the best we can in leading that change.
Well, thank you very much.
If you allow me, thank you very much for all the presentations. Rhidian, question for you, if you allow me. You were mentioning in your intervention the importance of incentivizing clinicians and leading clinicians to structure their data, let's say, by giving back results in terms of research, their opportunity of participating in studies, trials, enhancing their CVs, and so on. Mm-hmm. My question is that the best use of their very limited time and resources of clinicians? And the reason for my question is, wouldn't it be better if we could structure the information using other technologies that already exists, natural language processing, other what's your point of view on this?
Well, I'm a believer in technology enhancing the ability to deliver high quality care. And a colleague has talked about clinical decision support. And you're right to say about the time element. The brief here, I have taken it as junior staff. Junior staff are on a journey, hopefully to become senior staff and to become leaders within the healthcare environment. They need things to demonstrate that they have learned on their way. As a surgeon, I have to fill in a logbook. As a junior, to say I've done X amount of things. So having a balanced portfolio within your CV, when you give it to the person who might employ you, it's a value to them. It also is a value because it's a learning process. It makes you understand how hard it is to get data, how hard it is to validate data, to collate, aggregate, and to publish. Writing a paper, getting it submitted to a journal is a tedious process, is it not? But the satisfaction of seeing your name in print for life is of value. So I take your points about there is technology that might do it, but there is a learning process involved, which adds value.
May I challenge you a bit?
Of course.
One challenge, yes.
Promised, Professor. What if instead of logging data, which is essentially repetitive, boring for them, we give them the challenge of validating already extracted information with their clinical knowledge, with their knowledge of their pathologies, of the therapeutic areas. And instead of giving them, let's say, the rather, tedious and boring task of logging in information from medical records, we give them the challenge of, hey, here is the data set you asked for your publication, for your study, for your trial. Use your knowledge to validate that information.
I absolutely agree with you. Okay, absolutely agree with you. I'm yet to see it in a perfect world. To give you some my own data, I obviously work for Digital Healthcare Wales. I have the Associate Director of Research, Innovation and Data available to me, and it's quite it was quite easy for me to ask her, could you show me how good a surgeon I am, please? I'm a bladder cancer surgeon. The only thing they could show me was length of stay. I happen to have a fantastically short length of stay. That isn't a measure of skill. That's a measure of time. So what we need to do as clinicians is identify the things we want to measure. And then if your systems can come up with it, well, that will be fantastic. And I would support that.
We have to talk.
Thank you.
We have here some questions in the Zoom. As one participant asks, how can professionals be convinced to write down information in computer systems?
Is it for Seval?
It's general.
General, okay. I don't know, Seval, do you want to ask to answer this? You have no sound.
Yes, I would like to answer. First of all, of course, I agree totally with the professor. Leadership commitment is very important. I mean, without that one, you cannot move forward at all. Leadership is the top one, but if you don't have a good system, I mean, it doesn't make any sense. So if there's leadership commitment, of course, we are sure that they will allocate all the resources to make their system better. And having a good system, having a good quality system, having a good health information system is one of the key elements, I think. Of course, physicians are allowed to use all the data for publish and, to make some progress in their career. And we are also, this is also one of the incentive in our system. We are a university hospital, already mentioned you, 10 hospitals spread across all over the country. And we have also 1,600 beds and 10,000 staff and, treating almost 3 million patients per year. So one of the incentive that, but the process is very complicated. I mean, you cannot explain everything with one, simple solution. So how we are convincing our physician to enter their data? First of all, everything is paperless system in our system. So they don't have any other option to, summarize their findings into hard copy. How we did, of course, at the beginning, we kept the hard copies for a period, almost 6 or 7 years, and then now make all the system paperless, so they don't have any other option. And we are training. Continuously, in-service training, continuous medical education, and how to improve their system, how to write all their findings into the computer system, and so on. And there are many technical dashboards. The IT people are doing that, as well as the clinical staff or the senior staff also reviewing what they are writing, so on. So there are this is a very complex process. There are many things involved in this process, and also those reimbursement scheme, everything, different steps. So I cannot say only one thing that we convince our physicians to write all their findings into computerized system for one.
I think I'd add to that, Chair, is that clinicians work in different ways. You'll have orthopedic surgeons who don't carry pens, okay, because they believe that they never need to write anything down. They digitally dictate. I don't write in notes. I don't write on a computer. I digitally dictate, and my secretary types it in real time, and I sign the letters off electronically before I go home. If you look at radiology reporting, some fantastic examples of voice recognition in structured boxes. If you develop a protocol for reporting digital cellular pathology, you introduce standardization through the UI design. So there's plenty of opportunities to avoid using a typewriter, because there is a generation of people who just don't do it, can't do it.
Thank you. There's another question up there.
Thank you, audience, for self-organizing. Thank you.
So good. Hi, everyone. It's Angers, company Better. It's more of an additional comment maybe to this topic. I've been, I'm IT by background, but I've been doing product management and projects in healthcare for the last 15 years. So I've had my share of experience, hands-on working and shadowing how healthcare is done in hospitals and on a regional level. And obviously, as an IT company, we tried this digital transformation several times, and this was a question: how do we develop products, or how do we help medical teams take up the technology? And to be honest, it's in the last years, it's becoming even more apparent. Everyone in healthcare wants to use technology. It's they want to use really good technology that helps them. It's easy to use, it's intuitive. And I think that's the question we need to be asking. What kind of apps are we going to give them that are going to solve a concrete problem for them. And that concrete problem is not billing, administration, coding for the sake of, I don't know, some statistics, because then we're forcing them. And I've seen, we tried to do, and there were projects where we came up with we thought a great solution. They just didn't want to use it. But at the same time, some users showed me they had smartphones with apps they were using that were completely disconnected from their EHR, but it solved some of their problems. So I think when it comes to this, how do we make sure that end users actually use the products? We need to start thinking also as a system, how do we enable these smart solutions to enter the healthcare domain? Because the barrier to entry of, let's say, new innovative companies into the healthcare system is really, really high. So are we relying just on the old players to solve everything for us? And what are we going to do for new companies to be able to join? And also one thing that we need to think about is really there only one company, the big companies who can solve everything for us? Or are there other companies out there who can do so much better, or at least certain aspects, and how are we helping them to get more involved? So a bit of a provocation as well.
Thank you. I have one question for my colleague here, for Fernando, about the Wales system. We already spoken before the session, but I think it is interesting that you can put in public way. Your health information system in Wales is managed by the government or by one or more private companies? And what is your lesson stick for that?
Yeah, so it's very much a blended approach. Welsh government fund the national health in Wales. We've got 7 health boards and 2 trusts and 2 SHAs. We're Digital Healthcare Wales. We're equivalent to, say, NHS Digital. We've built a bespoke system for our patient administration system and for our clinical portal, but we used a blended approach with commercial suppliers for a single pack, so a radiology system across Wales and a laboratory information management system. This is, of course, has to be based on standards, and some of the pain has been that when you have 20 or 30 labs across the country, how do you standardize the way that they report their full blood count? So there's a process of data standardization and then data migration, and then you're in a much better position. So we design with our users. Every single health board and key stakeholder is involved in our design. We have a very strong clinical leadership group. We've introduced chief clinical information officers in every hospital, chief nursing information officers in every hospital, and we're now working with our AHP community. We have a strong link to primary care and the unions within primary care, because they're independent contractors. They hold data in a different way. I go back to this thing, it's about joint collaboration and it's about leadership.
But backbone is public.
The backbone is paid for by the taxpayer.
And is governed by it is the people that work in this backbone at public.
They're employed in the organization in which I'm one of the leaders. Yes, okay. Digital Healthcare Wales. Yeah.
Thank you very much. And we have another question now for Dr. Carlos Santos. First of all, I congratulate you by this unique project in Portugal. And my question is, how can it be self-sustained? Which kind of services that you could sell to other entities that could support system?
Can I use your?
Yes, for sure.
Thank you very much for the question. That's the main ambition, to be self-sustained, of course. The biobank has a price list. When we approved the regulation, the internal regulation, and all the documents concerning to the governance model, we also approved a price list for each kind of samples. And of course, we have to provide services for the departments within the hospital, and that will be part of our clinical activity and research activity. But for all the scientific community, they will be charged according to this price list. Actually, as I told in the beginning of my intervention, we started on September 19th, And on the very next day, on September 20th, we received the first collections from the Portuguese Society of Cardiology within this Porto study. And they accept, and we formalized an agreement about those prices. So that's the main goal. Of course, as a consortium, CAC can use the resources of Coimbra University and from the CHUSJ, from Centro Hospitalar Universitario de Coimbra, but we want to use it in the less possible way. If I may. Thank you.
Thank you. You have time for one more question. I have one question for Seval, if you allow me. Why do you pay incentive to healthcare professionals who adopt electronic health records? It is not an obligation by law or professional duty. Why do you must pay them to use these electronic health records?
Okay. Actually, we are not paying directly. Maybe I already mentioned you that. I mean, that is the system of United States. Medicare and Medicaid is paying. And if you ask at the country level for Turkey, we don't have that kind of system. But it is attached to reimbursement system. Actually, I think it is same for all over the country. If, because they use all the electronic data to reimburse the patients. This is health insurance. I mean, the Social Security Institute, there's a reimbursement scheme and the RG system for each incentive and each procedure. They are reimbursing what the hospital, use for that patient. So Social Security Institute checking all the information from the electronic health information system of the hospital. If it is accurate, accordingly they reimburse. So it is not directly paying. So it's a kind of incentive indeed. Hospitals are so keen on this issue because I already mentioned it first. I gave my example. 95% of my patients, has that this universal health coverage. Government paying all their costs. I mean, of course, I can ask in addition, it's a complex system. I can ask in addition, according to the hospital classification, but if all the data or all the information not accurate, so they are not reimbursing. Everything is digitalized. So that's why. Otherwise, it is not, like United States system. They are paying in cash for each, as you well know.
Okay.
Yeah, but not in our system, indirect system.
You want to make?
Yeah, I'll just say you can nudge through an incentive monetary environment. So in the UK, primary care, so the family doctors are independent and they're paid by demonstrating high standards of care in certain areas. So, for example, you might say people who are diabetic every year, if they're on a blood pressure tablet, they must have a kidney function blood test. That makes you collect the data in a certain way because you then have to present that you've complied to a thing to get paid for a thing. So there are mechanisms to nudge.
Yeah, sure. Well, we are right on time, so I'd like to thank Seval, Rhidian, and Karshant and TiagoAlfaro for these excellent presentations. And thank you very much for attending this session. Thank you.
Thank you very much. Thank you. Thank you.
Fantastic. Thank you so much, Chair, and dear guest speakers for keeping the time, and Zoom participants. Thank you so much for being so attentive and also in the room. Now going to break for lunch. So, oops, no, not yet the lunch time. It's going to be a marathon now until lunch, final marathon.
Somos o único hospital da Península Ibérica. Não, não vamos, não vamos. Obrigado. Com todo gosto.
So live stream can be cut now, please.